Welcome to Webisode 8 on drug testing. I'm Eric Morse, an addiction psychiatrist who has over 18 years of experience working in opioid treatment programs. In opioid treatment programs, we do a lot of drug tests. Most OTPs use urine drug testing, but in certain situations, like when a patient has end-stage kidney disease and stops making urine and is on dialysis, we may use saliva or blood tests. We correlate the results with the patient in front of us. We rely on the results to help us make clinical decisions on dosing, levels of care, and take-home stability. There may be variance on how OTPs make decisions based on drug testing. There may be variance on the quality of observation and validity of our testing. Are we doing mass spec confirmations? Are we relying on immunoassays? Are we testing for all the drugs that we should be testing for, like ETG, ETS, or carfentanil? How good is our lab? How good is our toxicologist? How accurate are our results? What are our cutoffs? What is an acceptable false positive or false negative rate? What is most cost effective? Do we want more tests, more expensive tests? Will we have to raise the patient's fees, which could limit access to care? Ultimately, these questions are up to each medical director of each OTP to ask and answer with the support of their team. They are fluid questions that change over time. I know that I needed my OTPs to test for fentanyl. The medical director has the power to make medical decisions and make changes based on medical necessity. In a different webisode, we will discuss interpreting drug test results. For now, let's focus on how we react to patients who consistently test positive for other substances. In general, drug test results should be addressed in medical appointments and in individual counseling sessions. Assessing the stage of change is important. Does the patient want to give up the drug? How are we with that? It may depend on the drug. Why are they using the drug? Can we find a legal substitute? In Webisode 6, we talked specifically about benzodiazepines, alcohol, and opioids. Now let's consider these substances and add stimulants to the conversation. If a patient is using benzodiazepines, consider a serotonin medicine as an alternative. Instead of opioids for pain, an NSAID or neuropathic pain modulator may be an option. For alcohol, prescribing a camprosate or Antabuse could be helpful. Naltrexone, of course, would precipitate withdrawal if they're on methadone or buprenorphine. And lastly, for patients using stimulants such as amphetamines, methamphetamines, or cocaine, consider whether an activating antidepressant might help. If the patient is unwilling to try another medication, or they are ineffective, what can we do? First, we can be patient and give them more time while they are changing people, places, and things. We can increase the intensity of counseling in the OTP, as well as outside the OTP, through the use of self-help groups, private therapists, or pastoral care. We can also insist the patient attends a substance abuse intensive outpatient program, commonly known as an SAIOP, or, if appropriate, require inpatient treatment. We also have the option of beginning a therapeutic taper until the patient is compliant with their treatment plan. Lastly, it may be necessary to discharge the patient or transfer them to another treatment provider. These decisions need to be made with the medical director's involvement. We like to use written contracts where we agree on the time frame and the level of treatment until the patient is capable of testing negative. And if broken, recontract with a therapeutic taper as a consequence of noncompliance. Complying with a return to psychiatric or medical care are at times part of our treatment contracts. To me, a therapeutic taper is used with a motivational interviewing technique of tipping the scales. Ask your patient, which is more important to you, your dose of methadone or buprenorphine, or the drug that you're continuing to use? A therapeutic taper might be 1 milligram a week, giving the patient time to decide to give up the other drug and test negative on a drug test. Discharge for continued use and failing contracts should be a decision of last resort, where the risks of continued use are outweighing the benefits of staying in treatment. We will often accept the patient back into the OTP if they comply with our clinical recommendation, which in most cases is inpatient treatment. A question that we commonly have in treatment team is, how long do we wait on a negative drug test before we start insisting on a higher level of care? The answer is, it depends. Is the patient coming into the OTP impaired? Is the patient missing days? Is the patient disturbing the milieu? Is the patient actively participating in counseling? Has the patient got into motor vehicle collisions, has fallen, or experienced other unsafe events? How is the patient functioning overall? If the patient seems to be doing well socially and occupationally, despite continued use, we might wait longer than for a patient who is functioning poorly. The abundance of carfentanil in our neighborhoods and the higher rates of opioid overdoses have moved the needle to intervening sooner. But also, not discharging the patient, as no treatment is more lethal than ever before. If you have further questions, please feel free to contact your state opioid treatment authority. Thank you so much for watching, and keep up the good work.